Hello, my name is Dean Contover. This is The Current Buzz. Today we have Dr. Raj Devarajan. Is that correct?
Devarajan.
Devarajan, okay. It's semi-Armenian, but it isn't, but we'll talk about that later. We're going to talk about colonoscopies. It's very important. He's one of the best in the area. He's in Boston Magazine as one of the top doctors. I just want to brag for you. His practice is the Middlesex, and I've never pronounced this word before in my life, but it's gastroenterology. Excuse me. I don't use it in my vocabulary, so if you don't mind. Your practice is where, Doctor?
It's in Acton, Massachusetts.
Okay.
Right on Route 2.
Okay. Easy to get to.
Very easy. It's right on Route 2, and it's before the Concord Rotary, so you don't need that traffic.
Yeah, exactly. Yeah. And how many people working in your?
Well, we have 6 gastroenterologists, MDs. We have a nurse practitioner, and of course, we have
the staff,
nursing staff, and ancillary staff. And,
right. Right. So it's an operation. You don't have to go to a hospital to get a colonoscopy?
That's right. Actually, most of the country, that's how it is done.
Going to a hospital?
No, going to what we call an ambulatory surgery center.
Okay.
And that's what ours is. It's an ambulatory endoscopy center.
Okay.
And that's how it's done most of the country. And in Massachusetts, the hospitals have traditionally been very powerful, and they have controlled access to these ambulatory centers. There was a moratorium that was passed by the Massachusetts Senate about 13, 14 years ago that said no more can be built. So mine was the second to last to be built in Massachusetts.
Oh, wow. Are you affiliated with a hospital?
Yes, all physicians have to be affiliated with hospitals because, if you're my patient and you're sick in some way and you need hospitalization, then I need to come and see you and attend to you. So we're affiliated. We're not employed by the hospital, but we have an affiliation. So our hospital is Emerson Hospital in Concord, and they want good physicians to be attending there because they want a good value for their hospital and good care. And we want to attend because we have our patients who might end up in the hospital.
Right. What is a colonoscopy?
So colonoscopy is a procedure with a scope, which is an instrument that we examine the large intestine, which is also called the colon. So colonoscopy is investigating the colon.
Right.
And it happens to be the only preventive test for cancer in medicine. For instance, if you were to get a mammogram, they could detect breast cancer once it's already there.
Right.
And if you're a smoker and you have high risk factors, you get a chest x-ray, you could detect lung cancer.
Right.
Colonoscopy, you can detect colon cancer, but you can prevent it because colon cancer develops from benign or non-cancerous polyps. And as they grow in size and degenerate, they go to cancers. So the objective of the colonoscopy, not just to find cancers, but to prevent it by removing these polyps.
Right.
Some people say, you know what, I just had some polyps, but they blow it off like it's just polyps, but that's the whole point, is to get those polyps out so that you don't get cancer. And in fact, we have shown since the 80s that colon cancer incidence has come down because of colonoscopies and awareness of colonoscopy. Right. The very first downward trend ever in colon cancer happened a few years after Ronald Reagan had a polyp. Wow. Because then it was in the news and people went to get their colonoscopies, and a few years later you'll see a dip in colon cancer incidence. The next big dip occurred when Katie Couric had her colonoscopy on television.
Good point.
That was another awareness, People who were not in the Reagan era, now in Katie Couric's era, they went to get colonoscopies.
Should I do a colonoscopy on the show someday?
Might get a lot of hits.
Now, colonoscopy, are you put to sleep, or how is that operation?
Yes, so you're sedated.
Okay.
And there's two types of sedation that you use. And one that we used for many years used to be a combination of a narcotic and a sedative. And that was called conscious sedation. Now, over the last 10 years, centers have been using the better form, which is called TIVAR, total intravenous anesthesia, with propofol. And it's a much cleaner agent where you go to sleep within 4 seconds. You don't feel a thing no matter what.
Right.
And when you wake up, you're more with it than you would have been with narcotics as in the past.
I see.
So most elite centers are using propofol or Tiva
Right.
for their patients. It's a much more comfortable sedation.
And you advise people not to drive that after you get a colonoscopy.
Because of the sedation,
Sedation, right.
By law, we say you can't drive, you shouldn't make any important financial decisions, things like that, till the next day.
Right. Okay. So, so what age group are we talking about of people getting colonoscopies now? It's come down, hasn't it?
It has. So originally, the recommendation was at age 50, every American starts to get a colonoscopy screening because we map out that colon cancer starts a little later, so we want to get the polyps before they go to cancer.
Right.
There are some caveats to that. If you have family history, in a first-degree relative or 2 second-degree relative, then it should be 10 years before, at age 40, or 5 years before the first cancer in the family, whichever occurred first. So if you had a father with colon cancer at 40, you'd be getting it at 35.
I see.
So that's how it was, starting at age 50. As I told you, colon cancer incidence has been coming down, but over the last 10 years, we have seen a rise in colon cancer at an earlier age. This seems to be a different, perhaps, process, but we're seeing earlier cancers. There's a lot of theories to that. It could be our food, our processed food, refrigeration, because we see countries that had all fresh food every day going to a westernization with refrigeration of food and going to the supermarkets. You see even those countries with higher incidence of colon cancer. India, for example.
So you think there's a correlation between refrigeration of food?
There's a lot of studies being done by that. We used to think, it's just processed foods.
Right.
And no matter how organic you want to be, there's always something in your refrigerator that is processed or refrigerated. And so there are studies saying, is that the process that
we don't know for sure.
We don't know for sure.
Right.
But because we're seeing earlier cancers, the American Cancer Society came out a few months ago and said, we should start at age 45.
That's the latest. It's come down.
That is
from 50 to 45.
It has from the American Cancer Society. Okay. But I should caution you that insurers go by the National Preventive Task Force recommendations, and they are yet to endorse the 45. They're still at 50. It always takes some time for these organizations to adopt.
I see. So colonoscopy is preventive. Who pays for the colonoscopy, or it's preventive?
So the Affordable Care Act mandated that colon cancer screening should be covered, period. So it is.
Right.
It is covered by insurers.
So that means you should go to get a colonoscopy as soon as possible if you're over 45. Is that correct?
Correct.
All right. So that's set. So it's really important to get a colonoscopy. Usually it's every 5 years once you get your first one. Is that my understanding of it?
No. There are 3 factors that dictate when you should get your next colonoscopy.
Okay.
The first is, and I know people don't like the prep. The prep is the hardest part of the procedure.
We'll talk about that.
And the prep has to be good, because if the prep isn't good, then your physician may say, I want to bring you back a little earlier because I may have missed some flat lesions because of the prep.
Right.
The second is, of course, the skill of the endoscopist to make sure that they got a good examination, their track record is good. So in our center, we follow national guidelines in terms of withdrawal time, in terms of what is the individual gastroenterologist's rate of picking up polyps. And there's a rate about 35, but ours is about 45. So we are very good at picking that up. So that's a second factor. The third factor is, what did we find? So normally, if you don't have family history, and you have good prep and they found nothing, you're good for 10 years.
Wow.
But if you have family history, it's every 5 years. If you have a bad prep, it could be a year, 3 years, 5 years, depending on how much they saw.
Right. In other words, how many polyps were there?
That's the last one, is what did they find?
I see.
If they found multiple polyps, you may come back in a year. If they found one or two small ones, you may come back in 5 years. So that dictates. And your physician will tell you at the time of colonoscopy or soon after, as soon as the pathology comes back,
right,
they will let you know.
Pathology, how long does it take after you do a colonoscopy?
So when we do a colonoscopy, we remove lesions. We send it to pathology the same day.
Okay.
Probably in about a week to 10 days, you should have all the results.
So you
back.
call them, or you drop a letter?
We do both.
Oh, you do both.
We call the patient and we write a letter.
If there's something there or not there?
Regardless.
Oh, okay.
If we took any specimens out, we'll always tell them it's either nothing or it's a polyp and you should come back in 3 years, 5 years, whatever. We'll always tell them.
There's different types of polyps. Explain the different types of polyps and what you do to them to get rid of them. And what's the most polyps you've ever seen in your experience?
So, the two major types of polyps are called adenomas or hyperplastic polyps. The hyperplastic polyps account for only 5 to 7% of polyps that we find in the colon. They do not have any malignant potential. So if your doctor is sure it's a hyperplastic polyp, they don't have to remove it.
Is that the tower type of?
No, well, we'll get to that. But the adenomas are about 95%. So most polyps in your colon are adenomas. And these are the type that go to cancer. So you want to remove all adenomas. Now, among adenomas, you can have what you call a tower or a mushroom type, where it grows outwards.
Right.
And then you have these flat lesions, what called sessile polyps, or flat polyps. They're a little bit more dangerous because they kind of spread in the wall, and you have to make sure you get all the cells when you remove the polyp.
I see.
So in that sense, they're more dangerous. The dangerous factors would be, are they flat? Are they big? And what does the pathology show? So these are the factors. That's why a doctor may tell you, you got to come back in 5 years. When you leave the endoscopy suite, 10 days later, they may call you and say, actually come back in 3 years because the pathology has now changed your surveillance guideline.
I see. Okay. So in regards to polyps, what's the most you've ever seen?
Well, to be honest with you, I think I took out about 28 polyps in somebody, and then I actually stopped because there were more.
Wow.
And I had to bring the person back.
Wow.
Because that's a lot of destruction to the colon as you remove all these polyps, and you don't want to increase the risk of tearing the colon.
Right. Yeah. So in regards to these polyps, you burn them out. Is that what you do, or you lasso them, or?
Yes, well, we use a lasso.
Okay.
And you go around the polyp and you cut. And as you're cutting, you may choose to burn so that it sort of seals the blood vessels, etc. Sometimes you just take it out without burning. There may be a little bit of blood, but we make that decision depending on who might have a bleed afterwards. A couple of days later, they bleed from a polyp site. So we make the decision depending on the orientation, the size of the polyp, as to whether to use cautery, that is the burning, or just simply snipping.
I see. What's your preferred method? I mean, does it matter? Or?
Well, it depends on the situation. I use both. All physicians use both, but it depends on which polyp.
I see. Let's talk about the prep. That's the most difficult in regards to some people.
I agree.
It's gotten better.
Much better.
Much better, so it's easier. So if somebody's interested in regards to the prep, let's go through the steps.
Right. So you might get some instructions, and one of the issues is there's a lot of instructions, and people tend to ignore some of these instructions,
Right.
and then they realize in the day of the colonoscopy that they didn't read all of the instructions. And remember, you might only have to do this once in 10 years.
Right.
So one of the first things I said is the prep has to be good.
Right.
So let's do the instructions properly so that you have a good prep.
Right.
So one of them is that you have to actually go on a low residue diet, which is exactly opposite of a healthy diet. A healthy diet is a high fiber diet, but we tell them to go on a low residue diet so that the prep is easier to clean out stuff, clean the colon
I
out.
see, right.
Second is we tell you to avoid.
Like soup or something like that? I mean,
You can do soup.
prior to that, yeah.
So second is to avoid certain medications if possible. For instance, you weigh the risk-benefit ratio. You have heart disease, you have stents, and you're on Plavix, you're on aspirin. We may tell that person, well, the risks outweigh the benefits to stop these things, so stay on it. Stay on the Plavix and aspirin. So we'll make that decision when you book your colonoscopy and we see your medical history. And then the prep itself is the day before you have to be on a clear liquid diet, meaning just liquids. And in the evening you take.
And that's not like tomato juice liquids.
It has to be clear. You can
It has
see
to be
through.
clear, see
Yeah,
through.
so Jello and
Yeah,
liquids.
liquid,
Yeah.
prune juice or something
Exactly.
like that. That's
So on the evening before your colonoscopy, you do half the prep. And then 4 hours before your actual colonoscopy, you do the second half. And we found splitting this prep this way gives a much better visualization for the doctor and much better chance that you don't have to be called back because of a poor prep. And some patients, and again, it's in the bell curve. 85% of people under the bell curve, when you give this prep, they have an excellent prep. 15% can fall on either side, meaning your constitution may be so good that you actually didn't need so much prep, because
Right.
you move things well on an ongoing basis. Some people fall on this side where they have a slow system, and even though they did everything on the prep schedule, it's not that good. So for those people, they may need a 2-day prep the next visit, and your doctor will advise you what to do differently.
We have you on the website. We have your office website
Yes.
up, and we'll give it to people who are interested in looking that up
Yes.
and getting information.
And we have a lot of resources on our website too, not just about colonoscopy, but other procedures and tests and commonly asked questions about diseases and afflictions. So anything related to GI health, liver disease, etc., will be up there.
Stomach problems,
Yes,
that type
exactly.
of thing, and so on. What happens once you complete your test? You go through the colonoscopy. What happens after that? So if somebody's watching and is concerned, what happens? You're stable usually after.
Right. So the risks of any procedure where you introduce an object into your body, the risks are, one, related to anesthesia, of
Right.
course, and that we'll know immediately whether you're a little drowsy, you need a bit more time to wake up,
Right.
etc. And you're fully monitored during the procedure. Your heart rate, your rhythm, your oxygen saturation, all of that is monitored.
Right.
Your breathing, etc. The second part of complications will be related to actually the scope, and there could be post-colonoscopy bleeding. Again, we take out a big polyp, they could have
Right.
some bleeding. And
That's a small percentage, though.
we're talking less than 1%.
Yeah, right.
And perforation, we're talking even less than 0.5%, if not 1/10 of
Right.
a percent, that you have tearing of the colon. That type of thing you probably know right away because the patient's in pain. We don't let anybody go when they're in pain.
Right.
But these are risks that have to be said. But again, the risks are, one in several thousands will have a perforation.
Right. Yeah. It's interesting. So, is there any other way to find out whether you have colon cancer besides colonoscopy?
So there are there are other methods such as CT colonoscopy and CAT scan, that is. And so that has not been validated. So the Preventive Task Force has not endorsed that. That's one issue. The second issue is that if they find something on the CAT scan, then now you have to go through the prep and have a colonoscopy. So you're really doing it twice, the prep, which is the main reason people don't get a procedure.
Right.
The other thing that is on TV often, they have very good marketing, is Cologuard, which is a stool test for DNA. They test your DNA and they test for blood. And they have very good marketing. Again, this has not been validated or approved by the U.S. Preventive Task Force. So at some point, these may become agents to use when they're better, but currently they're not.
In regards to colonoscopy, my complaint to you is this. I have friends that had colonoscopies, and they tell me that they are able to watch it on TV. And I wasn't able to watch my colonoscopy on TV. So that's my complaint.
Well, if that's the only complaint you have, that's good. So remember, the original sedation we used, the conscious sedation,
right.
It's called conscious sedation because you're sort of awake.
Right.
And those people can watch as we do the scope.
Right.
But I would say it's only about less than 5% of patients who can tolerate a procedure like this without fully being asleep.
I see.
So your friend may be in that 5%.
Oh, yeah.
He was comfortable watching the procedure, but most people with conscious sedation, they can't, they need more. And so the more and more you give with the conscious sedation, once your pain receptors start firing, it's tough to put them down. So adding more medication may not make you comfortable.
I see.
And second, the more narcotics you use, the longer you're going to be groggy. You'll be groggy the rest of the day.
Right.
That's why we went to propofol.
I see.
And you had this, you woke up, you were talking to me, you were fully
Right.
with it, etc.
Right. I was talking to you. Now, I only have 2 minutes left. How did you become a top doctor in Boston Magazine? How did that happen?
I honestly don't know myself because I don't know how these are. I don't know how these are picked. They say on their website
There are four out of 6 doctors in your practice.
in my practice, and we're very fortunate.
Yeah.
And I think you just continue to do good work. And but on the website, I wanted to find out how it was done, and they say it's by peer recommendations. That is, other gastroenterologists recommend that you should be picked.
I see.
So
Okay. So
I assume that's how it was done. I don't know.
Oh, okay. Because people use that magazine as gospel in regards to physicians, or are looking for good physicians, and that's what they use. I mean,
I should buy that magazine then.
Yeah. So I want to thank you for coming on the show. How are your sons doing?
Good.
Good.
Good. They
They're
both
physicians.
are good.
They're
Well, one
physicians.
is a physician. He's
Okay.
in training.
Okay.
Ear, nose, throat surgery.
Where?
He's in Texas.
Okay.
Yeah, and the other son he works for a consulting company.
Okay. Well, I just want to get the family in. I just want to make sure that we know that you have children and
Yes.
they're doing
Yes.
very well. And,
Thank you for asking.
Yeah,
Yes, they are.
that's important because I have a daughter, and she's starting to do very well for herself.
Very
So
good.
I want to thank you for coming on the show and explaining colonoscopies. It's very important that people get a colonoscopy, and if they don't, I'm going to do something about it.
Well, thank you for having
Yeah.
me, especially in March, which is colorectal cancer
Oh, is it?
awareness.
Oh, yeah.
So it's perfect timing.
Yeah,
Thank
good
you.
timing. I want to thank you very much.
Thank you very much.
Yeah.